Good morning. Welcome to Standing Up to Barriers, a multifactorial, multi-regional outlook on power standing mobility. I think it's not going to advance. So what's that? Thank you. For the sake of our presentation, both myself, Tilly, and Stefan discuss that we are ProMobile employees. What's that? No, thank you. You'd think after all this time I'd be good at this. So as I was saying, myself, Tilly, and Stefan are full-time employees with ProMobile throughout the globe. You are going to see ProMobile pictures in the presentation today. However, this is a generic presentation and not directed towards any of our feelings at ProMobile. So some things that we want to talk about we're going to talk about some of the clinical and both medically and functional benefits of power standing. We're not going to spend a ton of time here. The preface of this class was not on that, but we did want to just kind of start to talk about it a little bit. We're going to talk about some of the potential changes with global funding as a whole that we could potentially utilize to affect the procurement of standing power mobility. And then lastly, we're going to identify some barriers to how power standing mobility is recommended throughout the world as it is. So just a little reminder is mobility is a human right, both those of the individuals that we service as clinicians, as equipment suppliers, but also as ourselves. We want to be able to move and engage in our environment, and our patients and our clients should be able to do the same thing. So that being said, and I think as many of us in the room, I see a lot of familiar faces, thank you, that, when we meet an individual or we meet a handful of individuals, they may, let's say, all have cerebral palsy. They may all have a spinal cord injury, but they're so unique and individual despite the fact that they might all have the same disease. So it's a good thing to remember that people are not all the same, despite the fact that they might have that same disability. So we're going to pose some questions. You're going to see these questions 3 times throughout the class. Just some things to ponder and reflect on as we talk. So as clinicians and equipment suppliers in the room, do you prescribe primarily based off of, and maybe not just necessarily in regards to standing power mobility, but just in procurement of wheeled mobility and seating in general, do you primarily, make the recommendation based off of what is, recommended or accepted by funding? And then as, clinicians, are we able to empower both our clients as well as our communities that we serve, both from maybe a peer-to-peer aspect or, even family, to be able to continue to advocate for the rights of the individuals that we work with every day? So, like I said, we weren't really going to focus deeply on medical and functional benefits of standing, but we did want to highlight a few things. So power standing, for many of us, this is going to be a review. So just bringing it back. Power standing enables pressure redistribution. It may improve bowel and bladder function. It may increase range of motion and muscle length. It may promote bone health. We do know that it really does a great job of promoting bone health. It's probably one of the most common things when I ask people of what to think about when you think about standing in general, not just power standing. Bone health is the first and foremost thing that comes up. It may decrease spasticity in the lower extremities. It has a positive impact on mental health. And here in the US, while we don't get to have the luxury of using mental health or psychosocial benefits for justification for equipment, there is an aspect of mental health that I really feel strongly as clinicians, as equipment suppliers, that we need to kind of hold deep with these individuals. And so there's a lot of evidence coming out to support that mental health can be improved in our patients with the use of standing. So from a functional standpoint, and we included functional for a couple of reasons. You're going to hear some stories towards the end on various countries around world that utilize functionality of their individual really for the, kind of acceptance of power standing mobility. From many states that have, from Wisconsin, a neighboring state being Minnesota, we've been a widely accepting power standing mobility state and states for several years. But functional benefits was a big component of how we did that. So we do know from the evidence there's higher levels of independence, both with hand washing, with reaching. And the interesting thing is with that higher level of independence, that higher level of participation, we're actually able to see a decrease in demand in care. So we're giving individuals the ability to go back to being, functional in their daily lives if maybe they've sustained an injury, or we're allowing someone who's maybe had a neurological disease early on or is coming into a neurological disease to learn to adapt with that disease and become functional. So to start this off, we did a standing survey. Many of you may have participated in it, and we thank you graciously. So this just gave us an overview of what was going on from a global standpoint. So we had 226 responses from across the globe. We surveyed clinicians and equipment suppliers, and we really wanted to look at the barriers related to procurement of power standing mobility. So United States came in strong with 167 responses, followed by Canada, Australia, New Zealand. Europe was kind of put into a little spot by itself. Taiwan and the other was Israel, Belgium, and Chile. So then we dived deeper and we said, okay, who are we talking to? And so we looked at the profession or the credentialing. So the blue part, that's us as physical therapists. And yesterday I jokingly said I need to be very, very cautious about this. Coming in a close second was my occupational therapist. I'm very outnumbered today. And then, our equipment suppliers, our rehab assistants, product specialists, as well as sales reps. We had a lot of sales reps. My gone. Externals display was disconnected. Did I step on something? So I'll just keep talking. So we did have, some from not just our company, from other companies that got a hold of the survey and answered it, and we're really gracious for that. Okay, well, I'll keep talking because I know what's coming up next. So as our magic slide, we then looked at years of experience. And of those 226 people that we worked with or that we got the information from, a majority of them had 20 plus years of experience. So, it kind of, as I walked in and I said to somebody the other day, I've been in this industry for 20 years myself, and I see the same people, so we're a highly experienced group of individuals. We've been doing this for a long time, and we're very, very passionate about what we do. But as we started to, let me see if I can, did I mess it up? There we go. Okay. So we asked the question in the survey, what was the likelihood that you felt as a clinician, as an equipment suppliers who actually, recommend power standing mobility? It was a 0 to 10 scale, 0 being least likely, 10 being I do it all the time. 24% of that group said, it's like 1 to 3. It's a small amount. I'm not as comfortable with it. Halfway in that range was about 30%. And then the ones really likely were in that 40% range. So I think it kind of talks to the fact that we're starting to adopt this technology quite a bit better. So I'm going to go ahead and I'm going to pass it on to my Canadian colleague, Stefan, and he's going to kind of talk about some of the funding here throughout the globe.
Thank you, Ashley. Okay, how are we doing? Can we hear me here? Awesome. I'm going to try to contain my outdoor voice that I usually have. Okay, so I'm going to kind of pull it back to a little bit more of a 30,000 foot view for a moment. So we had talked about when we started this presentation about mobility, and it's a human right. So really at the end of the day, mobility is a precursor to social participation. And those persons who really lack mobility face limits to inclusion, limits to opportunity, as well as the possibilities. 45% of Americans actually lack access to public transportation. And sadly, a great number of urban transportation systems around the world are currently not accessible to persons with disabilities. But without personal mobility, persons really lack access to education, employment, healthcare, and social inclusion. And, I'd like to pull it into this, human right is to pull it into the UN Convention on Human Rights, which is a convention that was adopted almost 19 years ago by 168 countries around the world, including Australia and Canada. And this convention marks a major step forward for disability rights. It is a human rights treaty that reaffirms human rights as applicable to persons with disabilities. And so this convention really promotes equality and non-discrimination, full and effective participation and inclusion in society, equal opportunity to facilitate access to power wheelchair devices and assistive technology, and to promote, protect, and ensure full and equal employment of all human rights and fundamental freedoms by all persons with disabilities, and to promote respect for their inherent dignity. Further, facilitating the personal mobility of persons with disabilities in the manner and at the time of their choice. And to continue on about the convention, for the rights of persons with disabilities, persons with disabilities should have an equal opportunity to own and possess property, control their own financial affairs, and participate in all decisions that affect them. So going through this research, although the American with Disability Act is in place, but I was quite surprised to see that the United States hasn't ratified this convention at this time. So talk a little bit about that a little later. But we're addressing barriers, and now we're talking barriers to standing. But we've also noted some pain points, and organizations like RESNA, the Rehab Engineering Society of North America, can help bridge some of these gaps that we've seen in the survey that we were looking at. There are challenges to provision of appropriate assistive technology, and continuing education can be a challenge. So through organizations like RESNA, as well as certification programs through organizations like RESNA, including the Assistive Technology Provider Program, the Seating and Mobility Specialist Program, can really address some of these issues that we're seeing. But organizations like RESNA can also really help to affect and influence policy. So I'm going to just read this. I thought this was an appropriate text from the latest RESNA position paper on the application of wheelchair standing devices. One of the authors is actually standing here from the room. So, but anyway, pardon me. That's not it. Well, I still think this is this helps us at least talk about what we're going to be pointing out what we're trying to get at. So, but healthcare funding sources should consider these outcomes being healthcare outcomes and functional outcomes when examining policy and coverage as unique device characteristics, which relate directly to utilization and the person's individual context. Their abilities and preference and available storage space and financial situation should be factors in the choice, and a wide variety of device options should be available through healthcare funding sources to accommodate various situations. So, users do have the right to autonomy and choice and control, because at the end of the day, end users are the expert on themselves. Which kind of leads me to the why. Why are we here? Why did we decide to put out this survey? So Permobil has a large education department and a multinational education department, again, reflected by the people standing in front of you today. And when we get together to put our content together every year, it's always interesting to see how regional differences in funding can influence the content that we create, which kind of got the three of us to think, well, maybe we should take a bigger look at this. And that's really what started early in August to put this survey together to kind of get an idea of, how it's affecting, other people in different parts of the world. And anyone sitting here today wouldn't be surprised that one of the biggest barriers that leapt off the page with our data was funding. But there were some other themes that emerged from the data as we started to analyze it. And again, we'll look at it a little bit more deeply as we get through this presentation. But as I mentioned, I'm kind of taking the 30,000-foot view. So let's talk a little bit about some funding agencies. So we'll talk about the United States because here we are in Pittsburgh. And specifically, I'm going to talk a little bit about Center for Medicaid and Medicare and Medicaid services. So Medicare, part of the costs are, covered through monthly premiums for medical and drug coverage, deductibles, and coinsurance. Medicare is a joint federal and state program that helps cover Medicare costs or medical costs for those persons, perhaps with more limited resources. But both are sort of more based on acute needs and don't factor in long-term needs in many cases and stick to more of the in-home ruling. But again, individual state Medicaid programs do have some autonomy and still abide by many of the Medicare guidelines, but some states are already or currently moving to adopt power standing, and because they're seeing some of the positivities for the use of the equipment. And just suffice to say that many private insurance companies are also using Medicare guidelines to base the coverage for complex or CRT. But there are other funding models globally, and as of 2024, 72 countries of the 195 countries in the world use the universal healthcare coverage model. And obviously, each of these countries apply or use this model slightly differently, but overall, what is it? So universal healthcare coverage is really to help ensure that the population, and especially those most vulnerable, have access to quality healthcare without the need for suffering financial burden. The challenge was to try to encapsulate these funding models in one slide each, but I'll do my best here. So what is it? So it encompasses 3 dimensions that I have up here on this slide. So in the front is the coverage for everyone. Along the side is more the type and number of needed healthcare services that are covered under this model. And then the height of the cube is more the proportion of total healthcare service costs that are publicly funded and not subject to cost sharing. But really, again, rationale between different jurisdictions and how they apply this funding model obviously varies and reflects societal norms or system characteristics. So basically to say that, each country kind of really approaches this quite differently. But the challenge for governments that use this type of funding model is the need to balance the needs of the population as a whole, especially those most vulnerable, but not to create an enormous increase in taxation. So we're just going to look at a couple of countries around the world that use this model. So we'll start with Canada. So in Canada, the federal government transfers money for healthcare funding to each province and territory. So Canada has 10 provinces and 3 territories. And so it's almost analogous to having 13 little nation states that all apply these funding rules a little bit differently. So using the lens of standing, I just sort of pointed out that, some provinces, there could be available funding for persons under the age of 19. Some provinces actually do have available funding for, including Quebec and PEI, Prince Edward Island, but Prince Edward Island is currently reviewing funding for persons with, for standing devices. Quebec as well, there's some available funding. In some provinces, some clients may have the option to self-pay for the standing portion of a power wheelchair. And then there are several provinces that just don't cover standing at all. In terms of Australia, the NDIS, the National Disability Insurance Scheme, that is their funding, their federal funding program. And criteria for this funding agency is that the assistive technology must be reasonable and necessary and represent value for money. But the criteria is more related to function and participation. So for example, how would this equipment impact the participants' ability to have affect their informal or their formal supports, both in the short or the long term. So what does this mean? So really, clinicians in Australia are basing their justification for this type of equipment, and especially standing, on those functional needs. So, they're not really looking at the benefits of bone mineral density or circulation and all of the other points that Ashley talked about earlier in our presentation. In New Zealand, there are two different funding buckets. The Ministry of Health funding is a funding agency that is more applicable to persons with congenital disorders, so from a birth, whereas people who have an acquired disability are taking more from or are able to get funding through the ACC. Now, looking at other countries around the world that don't use this universal healthcare coverage model, there's, again, wide variations in the available amount of funding and how it's applied. So in Brazil, there's really only coverage for durable medical equipment. But because of the robust banking systems in Brazil, a lot of persons with disabilities will use a loan to perhaps help, or pay privately to help pay for their equipment needs. In countries like Colombia, it's a little bit more hit or miss. So for all intents and purposes, persons with disabilities have to sue the government in Colombia in order to get funding for their equipment. And because this system can be somewhat difficult to navigate, or some end users just aren't aware of this program, that a lot of times they're just not applying for funding. And then in terms of Singapore, persons with disabilities are afforded 40,000 Singaporean dollars for their lifetime to apply to their assistive technology needs. And then looking at Korea, there's really minimal government funding available. And so a lot of persons with disabilities are maybe applying through their employment insurance, or, and I think Tilly made sort of an analogy. It's kind of like buying a car. And a lot of the cases that she was telling us about, there weren't even clinicians involved. But at the end of the day, and I think, any of you who attended this morning's plenary, technology is quickly outpacing funding. And anyone who has been walking around or, mobilizing around in the exhibition hall, technical innovation is, it's happening, it seems almost weekly or monthly. But with this changing technology, it's really changing service standards. It's raising questions about appropriate and equitable distribution of this technology, as well as requirements for safety, efficacy, quality. These are all ongoing issues. And again, I thought this quote by Maida et al. Really kind of helped out. But basically, it's these requirements, technological, call for continuous monitoring and evaluation, and require commitment from all segments of society: elected officials, policymakers, health professionals, business leaders, and a robust governance structure that supports resilient health systems, responsive to citizens themselves, to establish people's needs, and can adapt to challenging and changing conditions. And I think that's a big challenge. Again, just talking about it this morning and seeing the plenary. But as we were analyzing our data that we got from our survey, we kind of discovered that maybe funding isn't the only barrier. And could there be potentially other barriers, and it could be us as clinicians? So to expand on this, I'm going to pass the baton over to my colleague, Tilly.
Not that tall. Okay, can you all hear me, and can you kind of understand my accent? I will try and de-Australianize myself, as we've discovered, although we all speak English. Apparently I say some weird things, so let's see how we go. So, that's a really great overview of funding, but, I'm going to call out therapists in the room. Could we be doing better to help overcome some of these barriers? And excuse me, one of the other questions we asked in the survey was, what other barriers are out there? And the clinicians who responded was really, really appreciative of the honesty that came out, and some reported, minimal experience just not having an opportunity to engage in prescribing power standing chairs. And, you know, I'm kind of hypothesizing, is that because they're not funded? So perhaps they're just not pursuing that. And they, you know, this technology is relatively new as well. Others also reported that it was outside of their skill set and scope of practice. So, you know, I'm questioning, well, how can we bring it within scope? How can we upskill our colleagues and the other therapists out there? So put your hands up, clinicians in the room. I know I've got lots of manufacturers and suppliers, but good practicing clinicians in the room. And this question, I really want us as suppliers and manufacturers to reflect on this, because we are a key part in the prescription process, is coming back to these questions that Ashley posed at the start. Are you prescribing what is available within local funding? And my colleague Tracy Lee called me out on this and relative, you know, really well. She said, well, but therapists are working within their bounds, and, you know, it's important that we work, you know, within our funding bodies and that sort of thing too. And I agree. But equally, are we doing best practice every time? Are we talking through all the potential options out there, even if it's going to be a struggle to get it through? Because, you know, are we also empowering our end users or our clients to advocate for themselves as well? So I'd encourage you to reflect on your day-to-day practice and think about, you know, am I striving for best practice day in and day out? And it can be taxing, you know, to be on the ground and front facing. So, you know, kind of summarizing, well, what do we think based on our survey, based on the research? What potentially could we do? Okay. First and foremost, you know, let's ratify the CRDP globally. You know, that's a big picture, right? Because ultimately this is really encouraging best practice and for users to be, you know, front and foremost of everybody's mind in this process, because they're an expert on themselves. Secondly, let's look at advocacy at the state and federal levels. You know, how can we be part of that to create the change that we want to see? And finally, as therapists, you know, yes, it's really important that we talk through, you know, barriers we have in Australia at the moment. You know, therapists are having a really, really tough time. So we're hearing lots and lots of constructive feedback. But in around that, what else can we be doing to contribute to the change? You know, how can we advocate, you know, to be part of that solution? Are we providing the whole story to our users? Okay, what are all the options available to them, even if it's going to be a really big struggle? What are the pros and cons? What routes are we going to have to go down? And are we encouraging our users to also be part of the solution? Are we encouraging them to stand up and advocate for themselves as well along the way? So in regards to the UN Convention of Human Rights, it is really, really important that, you know, we are making sure we are prescribing the chair to the person, not fitting the person to the chair. Because when we don't do that, you know, the risk of secondary complications are significant. That person can face, you know, barriers to accessing health services. They may or may not be able to access their education, barriers to employment, and struggle with other elements of community participation as well. And then, as I like to call it, this piece of equipment is going to end up in the room of doom in their home. You know, when you go out and there's that room full of the washing and all the equipment, we really want to prevent that abandonment as well. So, you know, as therapists contributing to this change, how can we make sure that each and every one of us out there and up and coming therapists, you know, are highly trained, you know, looking at accreditation and that sort of thing as well, so that we can, you know, create the community that we want to see into the future. And you know, how we're going to address these gaps, you know, really looking at expanding the funding models. How can we, you know, we are only, you know, one individual, but how can we contribute to that? I think even though some of us see us, I'm just a therapist. We're all therapists or, you know, working suppliers, but we can contribute to that change. You know, how can we also make sure that We are engaging in high levels of education. What does that look like? Who's providing it? And, you know, having that accreditation discussion as well for pros and cons. Not all therapists around the world are accredited to prescribe complex rehab. That's a soapbox of mine. I won't get on it today. But, you know, these questions, we need to start asking them as well. There are some amazing associations out there who are contributing to this change. So if you don't know them, you know, contact them, get on their website. In America in particular, you know, RESNA, even as an Australian, that's often my number one go-to. That's my first point of call. The Clinician Task Force, the American OT Association, Physiotherapy Association. We have these associations all around the world too. So make sure you're joining them and you're sharing information both ways, upstream and downstream. We have the World Health Organization, the International Society of Wheelchair Professionals. In New Zealand, Seating to Go runs accreditation. And that's just to name a few. Okay, so the community out there is huge. And when we come together, we can really share knowledge and create that change. But having said that, these aren't all the answers. I'm sure even in this room, by thinking outside of the box, we're all going to have a different perspective on how we can help overcome some of these barriers to prescribing standing power wheelchairs. And that's exactly what we saw from the survey. The therapists who did respond to the survey, they said, yep, let's change funding process. Easier said than done. But you know, that is one way we can help overcome the barriers. But other suggestions that our survey respondents said was increase to education and access to education, end user engagement and education as well. So really coming together as a team, increase partnerships with those advocacy groups, access to equipment was one. If you don't have the chair, you can't trial it. Okay. And, you know, demo, working, you know, as a manufacturer, demo equipment is expensive, right? You know, money doesn't grow on trees, but if we don't have equipment to trial, then it's really difficult to start the whole advocacy process. So, you know, this is, we're all a team here and we have to help overcome these barriers together. One really great example in terms of advocacy and people coming together was I thought sitting on the sidelines and watching this occur last year was impressive. So for those of you in the room who contributed to having Elevate, you know, now funded, I really applaud you. So well done. You know, this is really that combined effort of the Clinician Task Force, NCART, and Item Coalition coming together to get, and I loved the wording, so I'm just going to check, to have Elevate not just seen as a convenience item to one that was funded. So this shows that, and I know this wasn't just one thing done in 1 month, it was years and years that came together, but it does show when everybody, you know, suppliers, manufacturers, clinicians, politicians, we all come together, it's pretty impressive what can be achieved. So one recent example of that coming together. So it is hard. It's really hard, but it can absolutely be done. But having said that, it's been a bit of doom and gloom. We don't want it all to be doom and gloom because there are success stories out there. And we would really like to share with you a handful from around the world where clinicians and end users and parents and suppliers have all come together to overcome a number of different challenges. The first person I'd like to introduce you to is Sam. And the story I'm about to tell you is through the words of his mum, Tina. And Sam here, he has Duchenne's and he lives in a rural part of New Zealand. Okay. His mum said that he was really late to come off his feet and really started to lose his functional mobility around 16, 17 years old. At about 16, his prescribing therapist, so he came under Ministry of Health funding. So his therapist had actually gone through the accreditation process and was deemed a level 2 clinician. And at the time, Sam was prescribed a mid-wheel drive power chair with tilt, recline and legs, with the predominant goal of accessing his school outside. Okay. At around the same time, Sam's mum really noticed that he was having difficulty doing functional tasks, particularly out in front of him. He'd stopped leaning to reach things out of his base of support because he was really becoming quite weak and was struggling with fatigue. And for the first time ever, Sam was asking for help. He's a kid that just got on with life. He's a really, really great kid. And then they went to a power wheelchair football game that Sam was competing in. And his mum saw all the other boys. They had standing chairs. And she went, oh my gosh, Sam needs one of these. She went, I knew it in my gut that if he had one of these chairs, his function would improve significantly and probably have lots of other benefits. She didn't know what they were, but she knew as a mum. She's like, I know. At the same time, let's add another element in here. Sam was being moved from the pediatric services to the adult services. And he'd just had a chair prescribed within the last 12 months. So his mum was told at the intake that it would be at least 6 months before he'd be seen by a Ministry of Health clinician. Okay. But thankfully, the intake officer said, but if you have the capacity, you can see a therapist and pay that therapist privately. And thankfully, Tina was able to afford that. So they got a recommendation for a private therapist who came and saw Sam and his family. And at the time, the therapist was she's like, oh, he's getting a bit late. Typically, the funding body in New Zealand would be hesitant to fund it because of his age. Best practice, she came out, she did a full functional assessment with Sam and his mum, heard their goals, and could also really see that, as therapists say, that they're compliant. I hate that word, but that was the word that was used. And she went, you know what, Sam really deserves a chance to live his best life. So they completed an in-home trial, and the therapist wrote a really great report with lots of evidence. The therapist knows the funding system inside out, back to front. So she said, I really made sure that I met every single criteria. She said, when you go to a bank and you ask for a loan, they're not just going to give it to you without evidence. She said, funding is exactly the same. She had to justify the base. She had to justify the standing feature, and then she had to justify that extra cost that came with the chair as well. But thankfully, they did get it over the line. It was approved, and Sam really demonstrated an increase in function and participation over time. Now, Sam's mum is not blaming the previous therapist, but she said a power standing chair wasn't even discussed at the time of the mid-wheel drive prescription. She really feels that the therapist was out of touch with best practice or not aware of it. And she actually thinks that because they live rurally, that was a contributing barrier as well. And Tina said, if I can change one therapist in the room today, please share this story. And the treating therapist also said, use the network. In New Zealand, there's clinical advisors that you can pick up the phone and call at the funder to say, hey, help. How can I get this over the line? What else do I need to provide you to do that? So reach out to that network. I'd now like to tell you a tale of 2 power standing chairs in Australia. The therapist who shared these with me is a highly experienced physio who's been practicing for 34 years. She was a really big advocate for the National Disability Insurance Scheme when it was rolled out. And she actually said, I know the system inside out, back to front. I know the legislation. You have to know the legislation when you are prescribing complex assistive technology. Know the right wording and work within that reasonable and necessary and value for money. They're kind of those 2 key phrases we hear a lot in Australia. So her first young lady she was working with was Abby, a 21-year-old young lady with Rett syndrome, and had a very, very low conscious state most of the day. Okay. But her family, super, super active, very inclusive family. And they take Abby absolutely everywhere. They stand her really safely in her chair, even when she's low conscious state. And they also use all the power seat functions in a supine position, so they can do pad changes and things out in the community. So her original chair was funded about 7 years ago. At the time, this was not under NDIS. And, you know, it was partially funded through government, but also the family did some fundraising and that sort of thing. So the therapist at the start of last year went, she needs a new chair. It is beyond repair. And the therapist didn't just do a like for like, she did a full assessment. She reviewed how the standing feature was being used. She also went out and made sure, was this chair the right product? What other products were out there on the market? And was it still best value for money? And it was. So the therapist wrote a really in-depth report meeting all the criteria, and it was approved. It really was approved within 3 months, which is pretty quick within the NDIS. At the same time, however, she was working with a young lady by the name of Kimberly, and I have changed these names. Kimberly is 20. She has a tax CP, and oh my gosh, is she just a wonderful young lady. She is out in the community all the time. She uses standing painting is one of her main occupations. She's using the standing feature at school to receive awards, to make speeches. She actually goes for a walk down to the local shop with her brother to, you know, get ice cream and lollies and that sort of thing, or candy is the word you use. She goes to concerts. She stands so that she can actually see. She dances in her chair. She'd recently walked down the catwalk. So I'm looking at this going, oh my gosh, this is so function focused. This will be approved in no time. There are really clear goals. So this chair was 7 years old, and this is what she was using it for. And the physio actually reported she had minimal scoliosis, and they really believe standing contributed to that. She'd had no lower limb surgery, and her hips were not dislocated. And she is a W sitter as well. And this chair was beyond repair. It was even missing parts. So similarly to Abby, the therapist completed in-depth assessment, met all the criteria, submitted a report. It was declined. Kimberly and Kimberly's mum and the therapist actually feel that this report was not even read. And in Australia a month ago, we had head of NDIS admit that reports are not actually being read. So that's a discussion for another day. It was declined. And the appeal process took over 12 months and ended up at the tribunal, at which stage it was approved. But over this 12-month period, the therapist had to provide 50 additional hours and was unable to bill for these hours because there was no funding in the plan. And this is not the first time we've heard this. Okay, so had that therapist not been willing to do it and been able to, you know, generate some income elsewhere, how would this chair have been approved? And the impact that this had on Kimberly and her mum was, you know, when it goes to tribunal, it's very public. And they said, why does my life have to go public to the point of being broken for me to have function and to mobilize? So this is not an isolated case. There's a lot of good in NDIS, but, you know, there's a lot of barriers there as well. And now I'd like to hand over for another couple of case studies.
Thank you, Tilly. I'm going to introduce you to Brent. Brent lives in my hometown. He lives in New Brunswick in Canada, the East Coast. He's a young man with CP, and he's been a wheelchair user for his entire life. And when I first started meeting with Brent and his mom, Kim, one of the first things that he stood out to me and what he said was, when I started asking him some questions, he said to me, I just wanted to stand like anybody else when I was asking him about standing wheelchair. Kim is a single mom and has a long history of being an advocate for her son. She through her job has access to some insurance. And I'll talk a little bit about funding in New Brunswick in a moment. But when she and Brent approached Brent's medical team when it came time for a new wheelchair, that they wanted to explore standing, they were told that the provincial funding in New Brunswick won't cover for standing. And Kim being ever the advocate that she is, she said, I don't care, we're going to go for it. And so they did. And so funding in New Brunswick is that typically if someone has insurance coverage through their employment, they will get some manner of copay with the provincial funding agency. But as I mentioned, standing was not covered at the time. So that being said, the occupational therapist, the team, they went ahead and they applied twice and were denied twice. At that point, the occupational therapist who runs the provincial rehab seating clinic in New Brunswick, she's, listen, my caseload is too big. I can't continue this advocacy. I'm going to pass it back to you, Kim. And Kim took that football and she ran very far with it. So she started going through 5 different layers of bureaucracy through the provincial funding agency. Starting at the bottom, and she worked her way up. And although she met quite a bit of resistance at the end, everyone said off the record, keep fighting. So she did, to the point where she got beyond the bureaucracy, and she started talking to elected officials, the members of legislative assembly, with the elected officials that were representing Moncton, again, where Brent lives. And at one point, Kim was actually on the golf course advocating for her son to one of those elected officials, saying, my son needs this. And so, to my knowledge, Brent's the only person who's had a standing power wheelchair approved in the province of New Brunswick. And it wasn't approved through traditional means. It was approved as a technical resource. The total process took about 22 months. And during which when, through her advocacy, through the fight, Kim ended up having to take a $12,000 loan against her line of credit in order to get the chair for Brent, not knowing if the chair was going to be approved. And luckily, through the generosity of one of the local vendors, that once the provincial funding did come through, she didn't have to actually go through with that that line of credit. But of course, when he got it, and you see by the pictures, Brent he's a super fan of the local Quebec Major Junior hockey team, Go Wildcats. And he loves to, he said one of the other things he wanted to do was he wanted to stand at the national anthem. Here I have a picture of Brent standing at a local baseball game standing at the national anthem. And he loved being able to stand up at the hockey game. And when he received his chair, it was Christmas time. So, of course, I said, you got to send me some pictures of trimming the tree, which is what he's doing. So Kim and Brent definitely lots of activities of daily living that he was doing in standing. He learned how to make lunches for himself. He was able to increase his seating tolerance. He felt much better. But sadly, when I was talking with them, Brent, a couple of years ago, had experienced some major issues with his right lower extremity and had to have major surgery. And Kim had told me that Brent doesn't use his standing function much anymore. And of course, I started to assume, well, it's probably because the recuperation process, perhaps some pain. And she goes, no, I don't think so. And she actually asked him when in the middle of the interview, and she said, Brent, why don't you use your standing anymore? And Brent said, I thought this chair was going to help me walk. And it was pretty profound to hear him say that. So, but he still uses the standing function very much in a social, for that social participation piece. He is a very social young man. He's very well known in the community. And he still gets out to the hockey game. Here he is at the hockey game. But Kim had definitely said that, at the time when they were going through the demo process, the occupational therapist certainly was very transparent, saying that the funding wasn't really it's not going to be there, but they hoped that it would change in the future. It hasn't yet in New Brunswick, but she fought and fought and fought. But she did say that, she and Brent are very well connected in the disabled community. And she was saying that, not a lot of end users or their caregivers are aware of power wheelchair standing devices. And Kim basically said if Brent had access to a power standing wheelchair device when he was younger, especially when he made the shift from preschool to school-based, where the amount of available therapies dramatically changed, reduced, she felt that Brent would have likely not have had to have so many of the surgeries that he ended up having and is continuing to have throughout his lifetime. And I'd like to introduce you to Claire. We still doing okay for some time? All right, good. Claire is a young woman who lives in Montreal, Quebec, in Canada. And Claire has Stickler syndrome and a full-time wheelchair user. And as a result of her Stickler syndrome, she experiences a lot of cardiac issues, including tachycardia, which certainly she needed to go to the emergency room about once a month. And her team, including her cardiologist, had suggested, well, maybe we need to explore standing. And at the time, they had recommended that maybe they explore standing frame. So Claire is over the age of 19, and in Quebec, the standing frames are more relegated to persons under the age of 19. Plus, Claire lives by herself, or at the time, she lived by herself. So transferring in and out of a standing frame on her own was not an option. So luckily, she had a very strong team, a very strong occupational therapist who really fought hard. I went through the provincial funding, and at the time there was very limited funding for power wheelchair standing devices. And the first application was denied. And I actually became involved in this case as a clinical educator. I certainly helped provide a little bit more justification, help them beef up their application. The second application was denied. This time it was more denied on a basis of batteries. In provincially funded wheelchairs need to use specific batteries in Quebec that weren't really applicable to the standing feature of the chair. But they applied again, and they won. And subsequently, several wheelchairs, and actually now there's an available power wheelchair standing device on the provincial contract. But what stood out to me when I was speaking with Claire from a physical point of view is that once she was able to be in her power wheelchair standing device, it dramatically decreased the times that she would have to go to the emergency room, and decreased the amount of medication, heart medication that she needed. And she lost 30 pounds. And I said, oh, how'd you do that? And she said, I was just being active in a standing position. She also said that being able to prepare food for herself in a standing position, she was able to provide a little bit more nutritious meals for herself. But that very much had a profound 30 pounds. That was great. And a decrease in pain. And she said that, again, another ancillary aspect of being in standing was that she didn't need to rely so much on her pain medication. But functionally, what was really great, so Claire lives in a wheelchair accessible condo in Montreal, but unfortunately her building actually it caught on fire, and so she had to move. She's in a rental unit at the moment. She's waiting for her apartment to be fixed and renovated. But living in this rental unit, stackable washer and dryer, non-accessible kitchen. She said, because I had access to my standing wheelchair, I could still do my laundry. I could still clean. I could still get through everything I need to do to, my instrumental activities of daily living as well as my activities of daily living. But something else she told me that when she started using her power wheelchair, and she actually had the demo wheelchair for a weekend, and she said, I went to a barbecue. She said, and she's a long-term wheelchair user, she's a very social person. She said, to be able to socialize, to be able to participate socially in standing was huge. She said that social interaction piece was just amazing. And I just thought I'd end this case study with just a few statements from Claire that I thought were quite relevant. She told me that she was very shocked how many of the clinicians, as well as funders that she was working with, just weren't aware of power wheelchair standing devices. And she said that it seemed to her that funding agencies would rather spend a lot of money on sending her to an emergency room each month, as well as a lot of money on medications, as opposed to the extra amount of money that the standing feature cost for her power wheelchair. So, and she sent me some videos, and I just thought this one was really great. I'm going to end this case study. So she now lives with her boyfriend and another person with disabilities. And I thought that was a nice way to end this case study. So to bring it on home, I'm going to pass the baton back to Ashley.
Might as well. So why we did not, I mean, we didn't include any case studies from the US, and we did that on purpose. Because we wanted to highlight, just how standing can be impacted across the globe. But I think as a US clinician, many of us in this room have sat through or have been part of very, very similar success stories or failures, unfortunately, in regards to procurement of equipment in general, but standing power mobility. I meant perfect. So I want to tie back this to finish up the questions that we posed a couple of times. So after this conversation, and just kind of thinking through things, are we still as clinicians as well as equipment suppliers, because we're in this together, going to continue to just provide or allow for what's available in local funding? And Tilly talked a little bit about that, why that's our voices are important. And I often tell clinicians that I meet with is that, we didn't get some of the things that we have funded here in the US by sitting and accepting no. We got aggressive and we said, we're going to keep fighting for it. So is that something that we need to keep doing? As well as helping our clients understand what their options are, what their rights are, and maybe what types of alternative funding may be available for those individuals. And then lastly, bringing back that advocacy group. I had the privilege of working with Peter Thomas as part of the clinician task force, as well as a representative of Permobile in the process, that's still going 5 years later, to get these power seat functions covered. But it was that group of this industry, the amazing teamwork that came together. And so it does show that, we stand united and we fight together and advocate for the people that we serve, that we can truly make a difference. So can we continue as clinicians to empower not only ourselves, our communities, our equipment suppliers, but our patients and our clients as well, to really be advocates for themselves? One of the things I shared with the two of them yesterday is we often in the state of Wisconsin, and we are widely accepted with power standing mobility and have been for quite a while, is that we, in that process, asked our clients, our patients, to submit their own story with our documentation. It wasn't just my words. It wasn't my equipment supplier's information. They also submitted their information, their story, whether it was videos, whether it was pictures, or just even a written testimony of what these power seat functions can actually do for them. So to finish up, we didn't formally introduce ourselves at the beginning. We didn't want to waste time. We didn't want to talk about ourselves. But Stefan did mention we are a global team at Permobile. There's a lot of us floating around. And so if you have questions in regards to power standing, if you're looking to get access to just kind of having deeper conversations, definitely you can seek us out after class in the hall, down in the Permobile booth, or we can also help you get connected with your local clinician in the area, as well as your local sales team, to be able to help kind of walk through some of this stuff. So thank you guys all.